We're broadcasting from the Middle Tennessee
Electric Studios.
Electric Studios. Visit MTE.com. MTE.com. Middle Tennessee Electric, serving to make life better since 1936. Since 1936.
This is the WGNS Action Line, talking with Rutherford County newsmakers about what matters most to you. Now, your host, Scott Walker.
This morning on the Action Line, we'll be talking about colon cancer, some of the things you can do to prevent it, and the symptoms of colon cancer. Our guest today, Dr. Lindsay Green. Dr. Green is a family medicine doctor, and she is with Ascension St. Thomas Rutherford Hospital. She practices out of the St. Louis Clinic. Dr. Green, good morning.
Thank you so much for having me on this morning.
Before we start talking about colon cancer, talk to us a little bit about your background and what got you into family medicine.
Gosh, now you're taking me back. So when I was younger, my mom had breast cancer, and so our family had the unfortunate opportunity to meet quite a few doctors along the way, and I think just has always been something in my heart to kind of go into a field that can provide service and really relate to people in a way that is unique.
And so have you spent most of your career here in the Middle Tennessee area?
Actually, the most of my career now, actually 5 years as of the fall. And so before that, I was in Texas for 4 years for training and then lived in Memphis for 3 years post-residency and fellowship.
What do you enjoy most about it?
Well, I think in my current role, I'm a faculty member at the University of Tennessee Family Medicine Residency Program. And so I get to work with incredible resident physicians and be a part of their training, which is really rewarding and also really humbling. And so it's a really great experience.
Tell us a little bit about colon cancer, and are the numbers big here in Tennessee for those who do have it?
Yes. So colon cancer, colorectal cancer in general, is the second leading cause of cancer-related deaths in the United States and in Tennessee as well. The American Cancer Society puts out some estimates for the number of colon cancer or colorectal cancers every year. For 2025, the estimate is about 153,000 cases of colorectal cancer in the United States, with about 53,000 deaths related to this. So it is a really big issue, and the fortunate thing is there is really great prevention options.
It seems like we always hear certain statistics here in Tennessee, and you also hear, well, the numbers are higher in Tennessee because of the way people eat or their lifestyle. Is there truth behind that, and how does that relate to this?
A little bit. There is some truth to that. So when we talk about some of the risk factors for things like colorectal cancer, there are some things that we can't change. So age is kind of the number one thing we can't change. We know that colorectal cancer increases with increasing age. We can't change our family history. So if we've got a family history of some colon cancer or a personal genetic history of a genetic syndrome, we can't change those things. But there are some things that we can change that could decrease our risk. And so the big things we think about are things like being overweight or obese. Those things increase our risk of developing and dying from colorectal cancer. Also, there is now some evidence that having type 2 diabetes increases your risk of colorectal cancer, as well as things like tobacco use, heavy to moderate alcohol consumption, and then the big thing you mentioned, diet. So, we are kind of in the land of barbecue. And so actually red meat or processed meats can increase our risk of colorectal cancer as well.
That's interesting. I didn't know that about red meat.
Yes, sir. Mm-hmm.
And then processed meat, you always hear some kind of story about processed meat, how it's bad for you. And it just confirms it even more, I guess.
Yes, sir. Yes, sir.
So what could we be eating more of, I guess, to be healthier and avoid stuff like this?
Yeah. So a lot of it has to do with kind of the fresh fruits, fresh vegetables. What's interesting is there used to be some thought that increased dietary fiber would actually decrease your risk. But more recently, the data has kind of been controversial about that. So really, they're talking about things like healthy fruits and vegetables, maintaining physical activity, again, to try to maintain a healthy weight for your body, and then trying to decrease your risk of some of those other medical problems like type 2 diabetes as well.
As far as maintaining a healthy weight, it seems like over the years we've heard different things about weight, about what the BMI, and
Sure.
Supposedly, was that BMI, the index, was it changed as far as what the numbers should be?
Yeah, so I think that's a really good conversation to have with your primary care physician. The thing we think about with BMI is that the body composition is also really important. So someone's body mass could be different because they have a higher muscle mass versus a higher fat mass. And so those are really good questions to ask your primary care doctor.
Okay. And then going back to colon cancer itself, are there warning signs that we should look for?
Yes. So one of the things that we will talk about with our patients, we ask a lot of questions, and it's not meant to be invasive or intrusive. It's more for us to kind of identify some of those warning signs. So it sounds maybe silly, but pay attention to your poop. So we want to make sure that we're having kind of normal caliber stools, right? So we want to make sure we're not having those pencil thin stools. That can be concerning for some sort of growth that could be changing the shape of your stool on the inside of your intestines. We also want you to note if there's any blood in your stool. So that could look like bright red blood. It also might look like your stools are dark or kind of tar-like. That's kind of not necessarily what people might think of first when they think of blood, but blood can look different depending on where things are happening in your intestines. And then if you notice that you're having some unintentional weight loss, so you are just dropping weight, but you're not really trying, you're feeling kind of increasingly tired and weak, and you just kind of feel that, something's not right. Paying attention to your stools and kind of the constellation of all of those symptoms are things that would be warning signs for us.
Now, with the blood in stools, what are some of the other causes of that? For those who may say, oh no, rush to the doctor. And
yeah.
So what are some of those other things that could cause that?
Yeah. So most commonly, especially if it's kind of that brighter red blood, we think of things like hemorrhoids, which are very, very common. The other thing we think of too are even just run-of-the-mill medications that we can get over the counter. So we've had patients come in saying, oh no, my stool is black and I've had some upset stomach. And you dig in a little bit more and they've taken Pepto-Bismol recently. And so Pepto-Bismol is actually one of the common things that can turn your stools to look a little darker. Also, if you're taking iron supplements or iron tablets can also make your poop look a little darker. And then other dietary stuff. So if you eat a lot of beets, your poop can look a little bit more red. So
I bet you have these conversations all day, don't you?
I do. I also have toddlers, so we use a lot of this language at home as well. So
it's kind of like talking to a patient.
Yeah. We speak a lot of the same language.
Again, Dr. Lindsay Green with us this morning. Now, colon cancer, is that one of the main things you see at your office, or you see patients who have colon cancer?
Yeah. So as a primary care office, we are seeing everyone from cradle to grave as family doctors, and we really focus a lot on prevention. So we think about things like screening for cancer, so colon cancer, breast cancer, any of those things that we can try to identify the disease early. We will take care of a handful of patients, of course, in conjunction with our colorectal surgeons and our oncologists who have been through a colon cancer journey as well.
Things like, let's say, constipation or diarrhea, very common things to have, but are they tied to any warning signs of colon cancer? Yeah,
so constipation and diarrhea can be very normal. And so what we want to pay attention to are things like, how long is our diarrhea lasting, or how long is our constipation lasting? And with my constipation or with my diarrhea, can I identify maybe something different that I ate, maybe something that's causing this, and what other symptoms am I having in addition to my constipation and diarrhea? Diarrhea with a fever, totally different story, right? And so we take into account what else is going on.
And I would assume you've got some patients who have maybe they battled constipation on and off their whole life. Mm-hmm. And is that just true for some people? I mean, are their bodies just different to where that occurs more often than what other people see?
It can be, especially if you have patients maybe with some irritable bowel that tends to be more constipation heavy. We do think a lot about, as you mentioned, diet though. And so unfortunately in the United States and in Tennessee, our diet is much heavier in processed foods and things that don't necessarily promote colon health and colon movement, if you will.
For those who may have grown up with problems their whole life with using the bathroom and they don't use it the same way that somebody else may, and maybe they even had to have a section of their colon removed, are they at a greater risk of developing colon cancer?
Yeah, so it would depend on why they had to have their colon removed. So when we talk about the prevention or the screening guidelines for colorectal cancer, those guidelines really are addressing people of average risk. So this is not going to include people who have a personal history of colon cancer. So if you had part of your colon removed because of colon cancer, these guidelines are not going to apply to you.
That'd be kind of obvious.
Yeah, you would think, right? But similarly, if you have a personal history, even of something like Crohn's disease or inflammatory bowel disease like ulcerative colitis, these guidelines are also not going to apply to that group of patients too.
What is the most common thing that you see in Tennessee, like IBS, or what would it be?
From like a GI
This
standpoint?
would be, tied to all of this in some way.
Yeah, probably constipation, honestly. We do see a fair amount of diarrhea, but I would say constipation is most often what we see. People are very in tune usually with what their bowel movements are like and the regularity. And so if they haven't gone to the bathroom, they don't feel great. And so they will often come in being very concerned about that.
How often does a patient come to you, they sit down right in front of you and they say, well, I looked it up online and it shows that I've got colon cancer. That's the bottom line.
Yeah, the blessing and the curse of Google, right? So, I think part of our job is to listen and to hear the patient's concern, because they might have something that is constipation because they haven't had a great diet, maybe for a long time. And so our job is to listen to that concern and, again, really try to tease out some of the details. Do we have other warning signs? Do we have a significant family history? Are we up to date on our screening for colorectal cancer?
Now, going back to the age group of those who more typically, I guess, than not would be or would get colon cancer, what is that age that you usually see in office?
Yeah, so what's been happening is overall, the rate of colon cancer has actually declined in our older patient population. So really those over 50, 55. But what we've seen over the last 15 years is that a younger patient population, so patient in their 40s, have actually had increasing incidence of colorectal cancer.
It's scary.
It is. And so the United States Preventative Services Task Force, they're kind of the people who make a lot of the guidelines recommendations for primary care. They actually lowered their screening recommendation to start colorectal screening at the age of 45 back in 2021. And that was decreased from the age of 50 prior.
When you hear these statistics, maybe nationwide statistics, do you see similar results? Do you see similar numbers coming into your office? In other words, if they say, well, right now, it looks like a lot of people are getting colon cancer at the age of 45. Do you start seeing that here locally?
I think personally, in our residency program and in our clinic, we have seen younger patients, maybe closer to their 50s, early 50s. But, we also take care of patients on the inpatient service at Ascension St. Thomas Rutherford. And so, unfortunately, we do see a handful of younger patients who are diagnosed earlier.
And what would you think the reason for it is here locally?
It's really hard to say, Scott. I think we think a lot about just the general risk factors outside of family history. And some of those we talk about changeable or modifiable risk factors. We know that smoking is a big thing in the South. And so tobacco use definitely contributes. And then, as I mentioned, like our diet, sometimes it's really difficult to even have access to fresh fruits and vegetables for a lot of our patients. And so, I think the diet can really make things difficult too sometimes.
No, alcohol is another thing that you did mention. Mm-hmm. And, there was a long period of time where it was recommended we'll have 2 glasses of wine each evening. It's good for you. And then they kind of pulled back and said, well, no, we found out it's not quite as good for you as we thought. Mm-hmm. Where do we stand on all of that? And what is considered to the point of, well, you're drinking too much, this could put you at risk of cancer?
Yeah, I think the hard part is we don't have a set number, right? So the risk factor is, for the guideline says moderate to heavy alcohol consumption. We as primary care doctors, we have some definitions of what heavy alcohol consumption looks like for men versus women, because it is different. And so we don't have a set number exactly that we know kind of tips that scale. It's kind of more of a general term of moderate to heavy alcohol consumption.
Again, Dr. Lindsay Green with us today. And what are some of the other types of cases you see that maybe go along with somebody who has colon cancer?
Some of the other cancers or other diseases that we see?
Perhaps other diseases that are not uncommon to see, maybe even spread from colon cancer, or does colon cancer spread that easily?
Yeah, most of the time we're not seeing significant spread from colon cancer. We're usually otherwise checking it or catching it rather early. And a lot of that has to do with our screening that we're able to do. I think most times, because I am a family medicine physician, the other diseases that I'm seeing with colorectal cancer are some of those chronic medical conditions. So the things like type 2 diabetes, high blood pressure, obesity. Those are the three big ones that we typically see with a lot of our other cancers.
It seems like high blood pressure is something that more and more people have today. Is that true? And other than medication and exercise, are there other things we can be doing?
Yeah, so high blood pressure is extremely common. And again, lots of different reasons for having high blood pressure. Again, we think of things like family history, those things we can modify and those things we can't modify. So a lot of times we go back to things that we can change. So smoking is definitely a big one as well. It increases our cardiovascular resistance, and that's harder for our heart to pump against it. So tobacco use is a big contributor to hypertension, as well as things like alcohol use. And the diet with the processed foods, so much salt is added to everything in our communities. And so, again, access to those fresh fruits and vegetables and trying to maintain kind of a healthy body weight is going to be important as well.
Sleep and stress. Those are two things that you'll often hear about from time to time, and you'll randomly hear a doctor say something to the effect of, well, you need the proper amount of sleep. You need to somehow figure out how to get some of this stress off of you, be it at work, at home, wherever it is. But those are two things that we always hear can cause more problems in your life. What are some of the problems that can go along with that? And are you at an increased risk for cancer if you're working a job where you're getting 2 to 3 hours a night of sleep?
Yeah, so sleep and stress are huge. You're absolutely right. And the big thing about both of those things, that the stress in particular, is the elevated level of cortisol, or kind of that stress hormone. That increases our risk of things like diabetes. It can increase our risk of high blood pressure and kind of worsen high blood pressure if we already have it. Sleep is also incredibly important, especially if we think about things like sleep apnea. So if we're having a hard time sleeping through the night, if we're waking up super tired, that can have significant impacts on things like our blood pressure and our heart, as well as our lungs. And so you're right, they really impact many, many facets of our being. And as far as its relationship to things like cancer, I don't think we have great data that shows us for certain that stress leads to cancer. But I think living in a state of kind of that fight or flight all the time is going to run your body down in a way that makes you not as well able to kind of cope with some of the risks of cancer and things like that.
Hey, and then water. I know we should be drinking, all of us, probably more water each day, but drinking enough water or not drinking enough water, can that also play a role with colon cancer? Because water would seem like it plays a big part in digesting your food.
Yeah, and really water plays a big part in constipation. So oftentimes when patients get dehydrated or when they haven't taken in enough water, we do see some increased rates of constipation. Again, whether or not that's going to show an increased risk to cancer, not really we can say, but we do know that having not enough water intake on the regular can cause problems with the stool transit, mainly constipation.
Now, let's go back to some of those symptoms for those who may have colon cancer. Are there a lot of symptoms, and are there any pains that somebody may be experiencing, maybe stomach pain or what else?
Yeah, sometimes patients will complain of bloating, like they feel like their belly is kind of full. A lot of people might say they have the urge to have a bowel movement, but then they don't really feel relief after they've had their bowel movement. And so paying attention to that, some people just kind of blow stuff like that off. Oh, it's just something I ate, or maybe it'll feel better tomorrow. But again, when we ask some of those questions, we're trying to really paint the picture of what's actually going on and trying to put together the puzzle pieces of some of those symptoms.
So male versus female, are there higher numbers of colon cancer in one or the other?
No, it's actually about even. So the risk for women is about 1 in 26, and for men, it's about 1 in 24. So it's actually about even.
Okay. Mm-hmm. And then what about demographics as far as those who are white, those who are African American? Are there Are certain groups at greater risk?
Yes. So the evidence has shown pretty clearly that our Black patients, as well as our Alaskan Natives and Native American patients, are at increased risk of colorectal cancer, both getting it and dying from it, unfortunately.
So what are the reasons why for that?
Yeah, so the reasons are pretty complex, I think, just across the board. Most often, the literature cites things like inequity to access to colorectal cancer screening and then utilization of the screening. So we take care of our patients at the St. Louis clinic down the road, and we know many of our patients are significantly impacted by access with things like difficulty with transportation, insurance, getting time off work to even come to the doctor. And so there are a lot of barriers to care that our patients experience. And so that is one of the things that people think is contributory to that disparity.
For anybody who receives that diagnosis of having colon cancer, what are the outcomes as far as, well, they were at this level when they were diagnosed, we began whatever treatment there was available and moved forward with it. And then what are their outcomes versus somebody who doesn't receive the help quick enough?
Yeah, so only about 65% of eligible patients are actually being screened for colorectal cancer. And so that's not a lot, unfortunately. So my hope is that patients hear this and are willing to go to their primary care doctor and talk about this. The nice thing is with colorectal cancer, because of our screening options and the guidelines, we're actually able to identify many of the cancers earlier on. So we have earlier detection of that cancer, or even something called like the precancerous polyps. So we can address those. Now, it might mean that we need more frequent screening after we've addressed those polyps, but we've at least identified them before they've become cancer. So a lot of the kind of outcomes for treatment are really going to depend on what stage we're at when we're diagnosed. And that will kind of a little bit beyond the scope of the talk, but that kind of will be involving people like your colorectal surgeon, your oncologists, your gastroenterologists, as well as your primary care physician.
Again, our guest today, Dr. Lindsay Green. She is with Ascension St. Thomas Rutherford Hospital. And the topic today, colon cancer. How to prevent it, how to check for it, and what the symptoms are from it. We'll continue this conversation in just a little while. We'll be right back.
Hi, Murfreesboro. Do you need something for your pet? If so, swing by Animal City on Broad Street. We have it all. From premium pet food, fun toys, grooming supplies, and more. You name it, we probably have it. Whether you've got a playful pup, a curious cat, or even a fish that needs a little TLC, we're here to help. Our friendly team can answer your questions and point you in the right direction. Stop by Animal City at 919 Northwest Broad Street today, because happy pets make happy homes.
This is Peter Demas. Come eat with us at Demas's restaurant. A lot of times when you get steamed vegetables such as broccoli or cauliflower, it's either soggy. One of the things that we wanted to do was make certain that it was still soft, but still had a little bit of a crunch to it. And so we worked on the procedure of how to cook that. And then all of our vegetables are seasoned with our seasoned salt. We keep that seasoned salt at home, and I can tell you almost all the vegetables I cook at home have the seasoned salt on it. Come eat with us at Demas's restaurant on Northwest Broad Street.
Friends? Yes. The financial partners whom you've built a relationship with at Old National Bank are still at the Dr. Martin Luther King Jr. Boulevard location, right here in the borough. And so are the warm, homemade cookies.
Cookies are ready, dear.
Like Grandma used to make. If you need online and mobile banking, Murfreesboro's Old National Bank does that too. You and Old National Bank, better together.
Old National Bank at 2230 Dr. MLK Jr. Boulevard. Old National Bank, member FDIC.
The Good Neighbor Network, FM 101.9 and AM 1450, FM 100.5, and online at WGNSradio.com. This is WGNS Action Line. Now your host, Scott Walker.
This morning on the Action Line, colon cancer. Some of the things you can do to prevent it, how to check for it, and the symptoms of colon cancer. Our guest today, Dr. Lindsay Green. She practices out of the St. Louis Clinic. She is with Ascension St. Thomas Rutherford Hospital. If anybody would like to get an appointment there, do they just call? Are they taking new patients there?
Yeah, so we have a walk-in clinic every day. So you can walk in anytime, essentially from 7:45 until about 4 p.m. And one of our doctors will be able to see you there. We also have a phone number. You can look on the Ascension website and you can call the number and get an appointment. But yes, we are absolutely taking new patients.
What are some stories that may stand out to you over the years of treating patients and working with different patients?
Yeah, I think just really humbled by the privilege that we get to care for patients sometimes at their most vulnerable moments. I think unrelated maybe to colon cancer, but my specialty kind of within family medicine is caring for moms and babies. And so, I get to deliver babies pretty regularly. And I think it's just quite a miraculous and humbling experience to be able to share that moment with a family, something that I don't take lightly, and just really moved by that every time it happens.
When you look at how vulnerable a patient is when they first come to you, I'm sure a lot of them are terrified about whatever health scare they may be going through, and maybe it's something that develops and it is cancer. Mm-hmm. But I can't imagine those conversations behind those closed doors, because they're probably being more real with you about their fears than they ever have been at anybody else.
Absolutely. And that's why it's such a privilege to be able to be a part of that, knowing that maybe we're able to interact with patients and establish a relationship and a trust that they might not have previously had in the healthcare system, I think is really beautiful. And again, walking through something like a cancer diagnosis and treatment with a patient, an incredibly humbling experience, and also just a really moving experience for everyone involved, I think.
How often do you work with a patient and they come in thinking the very worst, but yet within a week after multiple tests, you're able to confirm, well, no, you don't have this and you don't have to worry. You're going to be okay. But how often do you see that change in people, from when they do come in scared to death versus you being able to reassure them, no, you don't have cancer?
Yeah, I think it probably depends on the patient's access to the internet, because if they've seen the internet, they probably come in thinking the worst. And oftentimes patients will kind of fall into two camps. There's the people who kind of catastrophize everything that's happening and they're really worried and they think they have cancer. And then there's the other group who actually might be pretty sick, but kind of minimize their symptoms and say, oh, it's just my normal belly pain, or I've been dealing with this for 30 years. And so kind of striking that balance of how can we sit and listen again to what their concerns are, and maybe address those in a way that helps them understand in a more medical way what makes sense, but also helps them feel heard and understood.
You do hear that you should go get an exam, I guess every year, every 12 months or so. But can you catch things on time as long as you continue that trend of every 12 months I'm going to the doctor?
Yeah, a lot of that's going to depend on some of your other medical problems. We would love it if everyone came to their doctor every 12 months. That would be amazing. The unfortunate trend is we see people when they don't feel good. So many people just don't go to the doctor if they don't feel well, or don't go to the doctor, unless they don't feel well. So we would love to see people when they're feeling well to be able to address some of these screenings. And again, that early disease detection, not just for cancer, but for things like diabetes and high cholesterol and high blood pressure.
If you do receive that diagnosis of having colon cancer, and maybe it's through a screening like a colonoscopy, then what is the first step after you receive that?
So it's going to depend on what the results of your colonoscopy are as far as kind of the staging of your cancer. So the nice thing about a colonoscopy is that it is direct visualization. We can directly see into your colon, and we can identify any polyps, any of those kind of precancerous lesions. And in a colonoscopy, we can take a biopsy, but we can also remove it at the same time. And so we can take a look at that polyp or that lesion on your colon and kind of see, are we cancer? Are we precancer? And if we are cancer, then there's going to be a host of other things that we'll want to do to see if cancer has spread to the lymph nodes or to other organs. And again, that's where that kind of multidisciplinary approach with some of your other subspecialty doctors will come in.
No, I know you said during that last break, there are other methods to screen for colon cancer besides that well-known colonoscopy that I'm sure everybody loves. So what are some of the other options?
Yeah, I'm so glad. So there are other options besides the colonoscopy. And what's really nice is with the guidelines, it tells us we should start at 45, and really we should be screening patients ages 45 to 75. But they don't play favorites with what type of test they want us to do it with. There are some that are recommended first line. So we talk a lot about the colonoscopy, but it's really intimidating to a lot of people. Maybe not the procedure itself, but the prep for the procedure. So before the colonoscopy, you do have to do a bowel prep. You spend some quality time with your toilet over the few days leading up to the colonoscopy. And the big reason for that is we have to be able to see things. The whole point of the colonoscopy is to take that camera and to be able to see things. But that is not what patients want to do a lot of times. And
but
so,
who would, I guess.
Yeah, right. So the best test for screening is actually the one that the patient will do. And so we have some other options. We call essentially kind of break it into two camps. We've got our stool-based testing and then kind of our direct visualization testing. So the stool-based testing is actual stool samples. So we're going to take a look at that stool to see if there are kind of trace blood products in that. So there are kind of three different types of stool tests. There is one that's just called the occult blood test, and it's a test that you can do at home. So the patient gets a little kit. They're able to take it home and do it. It does require kind of 3 separate samples, and it can be impacted by your diet. So things like red meat, if you take aspirin or things like ibuprofen or Advil, you can't take those before this test because it could cause a false positive. So that's kind of we call it the occult stool. We're looking for occult blood that we can't see to the naked eye in that stool. That test is going to be every year. So unlike the colonoscopy, which if you look good on that colonoscopy, it's every 10 years, this stool test is going to be every year. There's another stool test that, again, looks for some of that blood protein, but it is a little bit more sensitive and specific for the blood protein itself. And so you don't have to change your diet or your medications before you would do that. But again, it is an every year test. And so the benefit kind of those every year tests accrues over time. And so it does require that the patient is diligent about doing those tests every year. And I'm sure people have heard about Cologuard. So that's another stool-based test, a little bit different. It looks for blood, but it also looks for some kind of cancer DNA cells that are shed from that lining of the colon into your stool. Again, a specimen or stool sample that you collect at home and you kind of send it through the mail to the lab. So all of the stool-based tests essentially rely on the patient to be able to collect their own stool, and they come with a instruction kit and everything on how to do it. The Cologuard, or the DNA fit test is what we call it. You can do that every 1 to 3 years, so a little bit different.
Going back to some of the foods and things we should avoid in order to prevent things like colon cancer, you mentioned processed meat and red meat. Mm-hmm. Those, or at least the red meat, I know that's something that takes, I guess, the body a little bit longer to break down. That being said, foods that do take longer to break down, are they bad for us when it comes to things like colon cancer?
I don't think collectively or universally, yes. I think there are certain things that are a little bit worse than others. I think red meat being the one that's most notable. Because other things that do take a little bit more time to break down, even some like green vegetables, those aren't necessarily going to increase our risk of things like colon cancer.
And then what about items like nuts, popcorn, those types of things that your body may not be able to fully digest?
Yeah, so to our knowledge, no increased risk of things like colorectal cancer, but specifically the nuts and the popcorn, we do think about things like it's called diverticulosis. So kind of you get little outpouchings or little out pockets kind of in your colon. Those can bleed. Those can get inflamed and cause infection as well. So not necessarily the colorectal cancer risk with those, but other risks to your colon.
Let's go back to that colonoscopy, because I'm sure a lot of people, they may be getting one for the very first time this year. And you said the prep work, that prep for the colonoscopy, that is sometimes the most feared part. Is it that bad? Because you do hear stories about it, but is it really that bad?
Well, I have not personally had to do it yet. I'm not creeping on 45 just yet. But I've not personally had to do it. My parents have done it. You know, I think it's all for a patient. It's kind of what risk tolerance do they have, or kind of what annoyance tolerance do you have? I think the thing you have to be mindful of just as a primary care provider is, you know, if we don't have a good bowel prep and we don't get a great colonoscopy, you know, does it increase the chance that we'll have to repeat a test sooner? And that can be frustrating to the patient. We also think about things like, well, bowel prep might require time for the patient to be off work, and they can't afford to be off work. They either don't have the days, or they need their paycheck to be able to pay their bills or put gas in their car. And so these are things, as primary care physicians, we want our patients to be screened for colorectal cancer, and we want it to be a test that is accessible to them.
Sure. And now, outside of the awkwardness of doing this prep work at work, if you have to go to work that day, I get that. But if you're disabled, I'm sure it'd be really hard for you to do this type of prep. But if you're not, is it like just a bad case of diarrhea? What would you compare it to?
Yeah, I think it's probably a little worse than a bad case of diarrhea, because essentially you're given a very large jug of Go Lightly, is kind of what people call it commercially, and you have to drink that and not really have solid food. You kind of have to have a liquid diet. So it's usually a combination of things like the Go Lightly, Gatorade to try to not lose all of your electrolytes, and water over the course of a couple of days. And so most people feel pretty weak afterwards. I haven't had anything to eat for about 24 hours kind of leading up to the procedure. And you've just been pooping. And ideally, you want your stools essentially just to look like water by the end of it. And so I think it is a pretty bad case of diarrhea. I think patients would probably say maybe not necessarily have as much of the cramping or something like that as maybe a food-related diarrhea, but definitely a lot of time on the toilet.
Now, do you usually start the day off, the morning is pretty rough, or is it, by the afternoon, I felt a lot better. I wasn't having to use the bathroom every 2 minutes like I had been?
Yeah, I think, again, not from my own experience, but from what other people have told me, I think that first few hours is a little bit of a culture shock, just to be spending as much time on the toilet. And then I think, you have to just kind of power through to be able to continue to drink it. And, ideally, your poop or the fluid coming out of your body looks like water, not like poop. And so if you get there before, you've finished your whole container, great. But a lot of people do require the full container of that Go Lightly because it can be hard to stomach sometimes.
That's a lot. Again,
Yeah.
Dr. Lindsay Green with us this morning. And again, you work mainly out of the St. Louis clinic here in Murfreesboro. For anybody who is thinking about maybe asking their doctor for the first time about a colonoscopy, it sounds like, for the most part, it's nothing overly scary.
Yeah, I think for the most part, part of our job as primary care doctors, like I said, is to kind of normalize preventative medicine, to normalize the screening for things like this, and to highlight the fact that if we can detect something like colorectal cancer early, we're going to have improvement in treatment outcomes. If we can identify some of those precancerous lesions early, then great. Maybe we have avoided colon cancer altogether.
And for most people, they can be, for the most part, I guess, asleep during the actual colonoscopy. They're not going to remember it?
Yes. So it's usually that kind of dream-like sleep. And so somebody the other day just told me it was the best 15 minutes of sleep of my life. So yes, that is something also to consider when you're thinking about all of your different screening options, is that a colonoscopy, you will have to be sedated, kind of that dream-like state. So it will require someone to drive you to the hospital or to the surgical center for the colonoscopy and someone to drive you home. So it kind of requires another person to help you with that. And then, of course, we also talk about the risks of things like anesthesia for our patients.
And if anybody has any questions, because I know we're out of time, but if they do have questions, should they just start with their primary care doctor?
Absolutely. Absolutely. I hope that if you've heard anything today, that we've lowered the screening guideline recommendations to start colorectal cancer at the age of 45, and be willing to talk to your primary care provider about the many different ways that we can screen for colorectal cancer.
And again, with us, Dr. Lindsay Green, and once more out of the St. Louis Clinic, which is part of, I guess, St. Thomas. Thank you for joining us this morning.
Thank you so much, Scott.
The Action Line on FM 101.9 and AM 1450 Murfreesboro, FM 100.5 Smyrna. Listen and watch at WGNSradio.com.